All right, thank you and good afternoon. My name is Dr. James Harden. I'm the Associate Dean for Faculty Affairs and Curriculum and a Professor of Biostatistics in the Arnold School of Public Health. I'm also the co-lead of the Analysis Core of the CADMR, and I have the pleasure of moderating the next session and introducing our speakers. Our session number 4 is using secondary data and developing systems for Alzheimer's disease research. We have 2 speakers, and the first is Dr. Ney Ali Rodriguez. He is a clinical and translational investigator of neuropsychiatric disorders with a special focus on genetic factors affecting neurodegeneration and aging. Dr. Rodriguez joined the South Texas Alzheimer's Disease Research Center at the University of Texas, Rio Grande Valley in 2021 to study factors associated with the increased risk of dementia in Latinos. We also have Dr. Susan Aguinaga. Dr. Aguinaga is an assistant professor in the Department of Kinesiology and Community Health at the University of Illinois at Urbana-Champaign. Through her research, she creates culturally appropriate physical activity and dietary interventions for racially and ethnically diverse older adults with cognitive impairment and those at risk for cognitive decline. Both of our speakers are scholars from last year's Alzheimer's Disease Registry Workshop for Scholars of Color, and they will be representing their research conducted using Alzheimer's Disease Registry data. So please join me in welcoming our speakers, and I will give it over to Ney.
Hello, everyone. Thanks for this opportunity to share our investigation. And this is a very, very important point. Here I saw very useful and very related to our job here presentations. So let's, in order to keep this pace, let me share my screen. Let's see if I can get here. Okay. Please let me know if you are able to see my screen. Okay.
Yes, that's
so
fine.
Let's work. I don't have any important disclosure. I don't actually. This is a work that is being funded by myself. I don't have any funding available for this. The introduction. Alzheimer's disease is a leading cause of dementia in the Asian population. That's everybody knows this. But Latinos have 3 to 5 times more risk to develop dementias than the overall population, US. Some studies started by the NIH and NIA and the Alzheimer's Association have examined for possible causes of this increased risk, but lack of comprehensive information and a reduced number of Latino samples in those studies have put behind the answers. Basically, we have access to the NIA data and the EDRC's data, and we see that Latinos are not more than 10% of the sample, so it's still small sample sizes. Okay, so the Rio Grande Valley has the largest proportion of Latino in the US. We have here more than 70% of Latinos in the population, and most of them are speaking Spanish. The highest prevalence of Alzheimer's disease in the US, we also have this here. Some of the counties with also the lowest income in the United States are here. We don't have a public health system. So we have people having Medicare, Medicaid coverage, but they have to use it in private practice places here. Sorry, this is automatically on. So there are no public health system. There are no public hospitals here. All the hospitals are for profits and private. That's a big problem here. And we are at the border. So we have a lot of people crossing the border every day. I think this is part of the issue. Disparities are huge in social determinants of health, affecting negatively the Latino health and aging. So people don't have here good coverage. Most of the Latinos here don't have access to preventive medicine. There's a lot of pollutants. The water that we have here, try to drink it from the tap water is really terrible. It has a lot of things there. So you have to drink bottled water, or you have to use special filters to be able to drink the water that comes. And it's well known that, okay, there's a lot of pollutants because this is a rural area that has crops, and there's a lot of pesticides and things in the air. Issues with quality of life, poor access to preventive medicine, as I told before, and also lower educational attainment in the overall population. We have a high prevalence of chronic diseases that are for factor of dementia. So I'm going to analyze this specifically. Also, language is a barrier because most of the people who are attending them here are English monolinguals. We need providers, and providers are studying somewhere else. And there are few providers that are fluently bilingual. This is something that we are trying to change here. That's why this university has created the School of Medicine in this area. We need providers, local providers. This is a nice view of the area, the Sabal Palm. This is something just across the river, the Rio Grande. So this is actually the Rio Grande. It's not that grand, it's not that big, but it's important for us. So we are going to talk about the dementias and the risk factors that we are having here in this area. The valley is not a valley. We don't have any mountains that you can see here. The valley is just a term coined for the fertile area that has the Rio Grande around it. So it's a green area. Everything else around is pretty much semi-desertic. But this is a nice area, very fertile and very green. So that's why they call it the valley. So, so the Alzheimer's disease and related dementias. We have an overall prevalence in Texas about 12%. The Cameron County, that is this small, let me put here the highlighter, the laser pointer. Okay, Cameron County is the tip. There's where I'm living. Cameron County has a 15%. Hidalgo, and this is what we are having our ADRC. The Hidalgo County, that is the next to us, has 20%, and Starr County has 26%. This is more than double the ADRD prevalence in Texas. So all this area has a lot of migration. We share a lot of ancestry, and a lot of families live across this area. The tip of Texas is sitting here in Brownfield and Harlingen. Hidalgo, the next county, is where McAllen is. It's a little bit bigger city, anyhow it's less than 1 million people. And Starr County is more rural and has Rio Grande City is just a small town. Hypertension, this is very important because hypertension is a major risk factor that I would say is one of the major factors for any dementia. And the correlation with dementia is high, very high. In the database that I used, that was very nicely provided by Bernie, the R is 0.5, which is pretty high. The prevalence in Texas is huge. This is serious, 59%, almost 60%. But in our area, it's even higher. If you can see, there is a blue, darker blue shadow just across the border. This border is set by the river, by the way. So we have a huge influence here. Cameron has 65%. Hidalgo 67%, and Starr 74%. That's really terrible. If we think that these people are more prone to develop dementia. Diabetes, another problem. This is, I would say, maybe even worse because the prevalence in all Texas is big, 28% is really high compared with the national average. But when we see that these border towns are having 65 to 74%. This is really insane, and this is a big problem. The considerations here is that we are having have too high prevalence of hypertension and diabetes, means that we are expecting to see higher rates of Alzheimer later, because when this population gets older, the rates of dementias are going to be also higher. So the map is going to change from this image to this image in a few years. I would say maybe in the next 10 to 20 years, the map of dementia is going to look like this. So this is really serious. So basically, this is a time bomb that we have here in this area. So this is, it's not a joke. It's a real issue, a big health and public health problem. So we have to consider to do prevention. There's nothing else that we can do that's going to be so effective. So I've been working with an undergrad student. Now she's graduating this next month, and she's going for medical school, Lily Putignac. We have been working on considering what are the most effective preventive measures. So we have genetic factors that are related to high blood pressure and diabetes, and these factors have high effect sizes. Therefore, genetic study can help us to delineate the adequate preventive strategies for this population. There are some ongoing programs like Tu Salud Si Cuenta, that means your health matters. These are having effective ways to increase awareness and promote health in this population. But all these are aimed to adults, may work to lower, to curb a little bit the diabetes and high blood pressure. Basically, this program has exercising in different places here, some guidance for healthy food, but most people takes this not too serious. I think that the best intervention should start in the schools, because the teaching the kids healthy habits, they will succeed and will have better outcomes in the later. They should have permanent campaigns in the school. We also want to talk a little bit about disparities. Bilingualism. Here in this area, everybody has to speak Spanish. I would say in Brownsville, more than 75% of people in the street are speaking Spanish as a first language, and then they can use English also. But it's important. Spanish is a way to keep alive the heritage. So it's considered part of the culture. And but we have some things that, for example, people say that, okay, if you learn a second language, you will be taking away dementias. This is not true. There are serious studies that saying that, okay, dementias are appearing in high rates also for bilinguals and for multilingual people. The monolinguals have better listening comprehension than bilinguals. This is also very well studied. So if you speak more than one language, your listening comprehension is lower because you have more things to process in your brain. And also, something that we are seeing here in the ADRC is that, okay, patients with advanced dementia, they start losing the second language and they revert to the maternal language. Something that was really surprised to me is when I analyzed the NAC data, the National Alzheimer Coordinating Center data here, and been doing these tests for the subjects that we have in the program, we see that this is really striking. Okay, there are big differences between non-Hispanics and Hispanics. Basically, these are people speaking English and people speaking Spanish. But there is a big step in each one of the categories. And at the base, we have the groups are the CDR. So these are the normal controls. 0.5 are the mild cognitive impairment people. 1 and 2 are dementias. And there's always a big step between the scoring on the testing for Hispanic and non-Hispanic. But what is really mm, against the logic is that Hispanics, normal Hispanics, are scoring lower than non-Hispanics affected by mild cognitive decline. What's happening here? Some of the Hispanics are not being assessed in Spanish. They are assessed in English because they say, okay, I speak English. I went to the school in English, so I take this. But there are some parts of the language that are tested that are not formal. The most informal, the hard language. That's part of the whatever you use in your house, from your early childhood. It's going to fail in that way. You need to do it in your own language. So we are changing. This is something that I talk with some people related to these tests, and they are saying, okay, we are going to generate a new normative based on these findings, which is very good. We also have another problem here, what is called neighborhood disorder. Christian Maestre, he's a architect working with us, analyzing the architectural features of this area. And this area has a lot of the functional aspects of the urbanism. We don't have sidewalks, therefore there's a poor walkability here. There's no accessible area. So once one person cannot walk well, is confined to their home forever. So this gets worse, the independence, and if you cannot walk, your cardiovascular health is going to be worse and you will get easier dementia. Also, disruption of human activity by structural elements. For example, people are parking their cars in the area to walk, and this is something related to education, definitely. We also have other consideration, the obesity in the Latino community. This is, I would say there is a huge cultural context in communities that have experienced during generations scarcity of resources. Once the people get available, sorry, I see. Okay, sorry, we're past the limit. Okay, I will wrap up. So scarcity of food means that people teach the children to eat more. Also, the intolerance to glucose is an ancestral trait. And we have a very early onset for cognitive decline here, so we have to study that. Social and economic burden is obvious. And we have a little bit of inflation because we have winter techs and people coming from the north here to escape the winter. And also we have a large undocumented population that is also sometimes counted. So we are incubating here a public health crisis in the next year because of the Asian population is very vulnerable. We have a highest dementia rates that are product of a combination of metabolic, cardiovascular, social, education, and cultural factors. And a registry can help to organize and follow up these preventive efforts and curb the correlated public health issues. Thank you, Bernard, Rana, Maggie, Quentin, special Quentin, so nice coordination, and the whole team for this opportunity. Thanks.
Mhm. Thank you, Nay. Appreciate it. And so we're a bit over time. So if you have some questions, please put them into the chat, and I'll go ahead and introduce our second speaker, and we'll see if we can make up time to get all of the questions answered. Dr. Aguinaga, please.
All right, thank you. All right, hello everyone. My name is Susie Aguinaga, and the title of my study is Association Between Physical Activity, Fruit and Vegetable Intake, and Subjective Cognitive Decline. And I used the Behavioral Risk Factor Surveillance System data from 2019 to conduct the study. So subjective cognitive decline is the self-reported experience of worsening or more frequent confusion or memory loss. It is a form of cognitive impairment and one of the earliest symptoms of Alzheimer's disease and related dementias. In the US, 1 in 10 adults who are 45 years or older report subjective cognitive decline, and those who report subjective cognitive decline, about 66% have 2 or more chronic diseases. Now, experiencing cognitive decline has important implications for these individuals. For example, they may have difficulty managing their chronic diseases. They may experience difficulty cooking and paying bills. And most importantly, they are at increased risk of mild cognitive impairment and Alzheimer's disease. So we know that these individuals have multiple chronic diseases, and that a third of Alzheimer's disease cases worldwide are estimated to be attributable to modifiable factors like diabetes, obesity, and hypertension. Now, given that Alzheimer's disease is a complex multifactorial disorder, targeting modifiable risk factors could serve as potential targets for preventative effects. So we're all aware of the many benefits of physical activity, including a protective effect against cognitive decline and reducing risk of Alzheimer's disease. However, only about 28% of men and 20% of women in the US meet guidelines for both aerobic and muscle strengthening activities. And meeting guidelines decreases with age, with only about 13% of adults 65 years and older meeting guidelines. And as a reminder, the physical activity guidelines consist of engaging in 30 minutes of moderate to vigorous physical activity 5 days per week. So we also know that following an overall healthy diet is a recognized strategy to prevent cardiometabolic risk. Dietary factors like reducing intake of saturated and trans fats, increased vegetable and fruit consumption, and dietary intake of vitamin E and B12 are associated with a reduced risk of cognitive decline and Alzheimer's disease. Now, similar to physical activity, diet quality among US adults is low. Only 1 in 10 adults get enough fruits and vegetables per day, which consist of consuming 1.5 to 2 cups of fruits and 2 to 3 cups of vegetables per day. So we know that cognitive impairment in Alzheimer's disease is driven by a combination of genetic, vascular, metabolic, and lifestyle-related factors. So there has been emerging research examining the potential of dementia prevention through risk factor modification. So research targeting several risk factors simultaneously has recently garnered attention and could be necessary to obtain optimal preventative effects. So because physical activity and diet have been associated with the reduced risk of cognitive impairment in Alzheimer's disease, these modifiable behaviors may be especially important among individuals who are at risk of subjective cognitive decline. So the purpose of the present study was to examine the combined association of physical activity and fruit and vegetable intake on subjective cognitive decline. So I used data from the 2019 Behavioral Risk Factor Surveillance. The BRFSS has a cognitive decline optional module, which measures subjective cognitive decline, and 27 states in the US included this optional module. So the study included 3 variables of interest. The first was subjective cognitive decline. For this question, participants were asked if in the past 12 months they had experienced confusion or memory loss, and whether it is happening more often or getting worse. So a yes response would indicate the occurrence of subjective cognitive decline. And so this was the only question that we used. For physical activity, participants were categorized as either meeting physical activity guidelines, engaging in some physical activity, or no physical activity. So again, meeting guidelines meant engaging in 150 minutes of physical activity or more. Some was anywhere between 1 and 149 minutes, and none was 0. So for fruit and vegetable intake, participants were categorized as either consuming 1 or more fruits per day, or less than 1 fruit per day, and consuming 1 or more vegetables per day, or less than 1 per day. So because we were interested in examining the combined association of physical activity and fruit and vegetable intake on subjective cognitive decline, we created variables consisting of physical activity and fruit and vegetable intake categories. So participants could be either in the high physical activity plus high fruit and vegetable intake, or low fruit and vegetable intake, some physical activity, high, low fruit and vegetable intake, and then no physical activity, high, low fruit and vegetable intake. And so our hypothesis was that engaging in high physical activity or some physical activity plus high fruit and vegetable intake they would be less likely to report subjective cognitive decline. So again, really looking at the combination of some physical activity or high high fruit and vegetable consumption, and comparing those with high physical activity, some physical activity, no physical activity, but with the low fruit and vegetable intake. So we ran a logistic regression to examine the association between physical activity and fruit and vegetable categories and subjective cognitive decline. We had a couple covariates in there: age, gender, race, income, and education level. A total of 107,000 participants responded yes or no to the subjective cognitive decline question. 88% of these participants reported not experiencing subjective cognitive decline. Adults 65 plus were more likely to report subjective cognitive decline, but there was no difference between adults ages 40 to 64 or 65 plus. In terms of activity levels and fruit and vegetable intake, those who were engaging in no physical activity and 0 minutes of physical activity, and those who consumed less than 1 fruit and vegetables per day were more likely to report subjective cognitive decline. So in terms of our findings, we see that meeting guidelines and high in fruit and vegetable consumption was our referent group. We see no differences between the group who was meeting guidelines and those who had low fruit and vegetable intake, and no differences among those with some physical activity and high fruit and vegetable intake when compared to the referent group. However, we do see a significant difference among individuals who engage in some activity but had low fruit and vegetable consumption, in which they were less likely to report no subjective cognitive decline. And individuals with no physical activity, regardless of high or low fruit and vegetable consumption, were less likely to report no subjective cognitive decline compared to the referent group. So we also saw that females were 1.4 times more likely to report no subjective cognitive decline compared to males, and that individuals in all income categories below 50,000 were less likely to report no subjective cognitive decline compared to individuals less than or greater than 75K. We didn't see any significant associations with education, age, or race. So in sum, we see that individuals meeting the physical activity guidelines, regardless of fruit and vegetable intake, has no association with subjective cognitive decline. Individuals with some physical activity and high fruit and vegetable intake have no association with subjective cognitive decline. However, where it gets a little bit interesting is among individuals with some physical activity and low fruit and vegetable intake, where we see a lower likelihood of reporting no subjective cognitive decline. And for individuals with no physical activity, regardless of fruit and vegetable intake, they have a lower likelihood of reporting no subjective cognitive decline. So what does this all mean? So more recent evidence has emerged on the benefits of engaging in some physical activity. So there's, again, emerging evidence that says that you should strive for the 150 minutes, but you will still yield benefits by engaging in lower amounts. And really, there's no minimum threshold for obtaining benefits from low thresholds of physical activity. However, individuals engaging in some physical activity, and so those who are not quite meeting the guidelines, may not really be reaping all the benefits, in part due to their low fruit and vegetable intake, which may be contributing to their increased risk for subjective cognitive decline. Also, the individuals who are not engaging in any physical activity levels, no matter their fruit and vegetable intake, are at greater risk of subjective cognitive decline. So we also saw that income has a role with subjective cognitive decline. So individuals with lower incomes may have greater difficulty accessing physical activity resources and purchasing healthy foods, which may result in low levels of physical activity and poor diet quality, which may in turn have an impact on subjective cognitive decline. So overall, future work should focus on promoting multiple lifestyle behaviors, such as the physical activity and dietary guidelines to reduce risk of subjective cognitive decline in Alzheimer's disease. And also keeping in mind that when conducting this work, researchers may consider recommending community-based programs and foods that are affordable and culturally appropriate. So I just want to thank all the organizers, and I'm happy to take any questions. Thank you.
All right. Well, Dr. Aguinaga, if you'll stop your share, we'll see if I'll check the chat here. I do have a quick question for you.
Sure.
Did you get a sense in looking at the models that you ran, which had the stronger effect on these things? Was it physical activity or the dietary restrictions?
I didn't get a sense of which one was stronger because it was combined. So it was a combined variable. So I didn't separate physical activity and the fruit and vegetable intake, but definitely something that I should be doing as well to look at the independent effects as well.
Sure. And Nay, I wanted to ask you specifically about the prevalences that you mentioned that were so extraordinarily high. So it went by me really fast. And so I wondered, what subpopulation were you talking about? Because at first I was thinking 60% of all Texans have hypertension. That can't be it.
No, we are talking about these are statistics from Medicare, Medicaid, no? And these are statistics in the South Texas. This is we are talking about this is the border between Texas and Mexico.
Sure.
And we are located just at the tip of Texas, between Texas, Mexico, and the Caribbean, the Gulf of Mexico.
Yeah.
And here there's a population. I would say the ancestry of the population is mostly Mexican, Mexican, basically. Because 100 years ago, 200 years ago, this was all dominated by the mix from Spaniards and the native people here. So, these are the ancestors in this area. So this is one of the cases.
Is it still 60% of the people in that region, or 60% of the 65 and older people in that region?
Yes. These are Medicare data that I shared with Nay.
Okay, just wanted to make sure.
And it's the CMS chronic conditions database for Medicare recipients, and it's a little older now, but it's 2018. And if anything, I think Nay is right, and that would actually be worse. So we are talking about people with comorbid conditions that we can derive from the Medicare database for Texas, and that's at the county level, and that's the sort of data we used in West Virginia as well for our advocacy.
Exactly. Yeah. It was great. I really appreciated listening to that. I'm native Texan. I'm from San Antonio, so I was very interested to hear about things about my home state. I haven't been there in decades, but still, I'm headed there this weekend.
That's nice. Yeah. Well, the South Texas Alzheimer Center is a coordinated center with San Antonio. So Suda is a PI there, and Gladys is a PI here. So we are sharing half and half the numbers of this year. We started 1 year ago, and we have a small sample size yet, but we are trying to grow and trying to do something, because something that we are seeing is that the age of onset is too high, too early. We are seeing people here frequently with cognitive decline after 40 years old.
Wow.
Or 45. Yeah. That's stupid. We cannot allow this. We have to keep our people. So we have to do something.
Exactly. Well, thank you both. I'm checking the chat over here. I haven't seen any other questions.
So I would like to. I know that there is a lot of people in the audience that may know way more than me on this topic. So I will appreciate a lot of input. Any other additional comments, please feel free to send me an email. We are really open to listen suggestions. Definitely. Thank you.
Absolutely. Absolutely. I'm sure all of the presenters would appreciate that as well. Well, good. Well, I thank you to both of you again. I really appreciate your time and efforts to put these things together and for being willing to answer these questions. I think at this point we have a short break.